Good afternoon, everyone, and welcome to today's webinar, Meeting the Mental Health Needs of Medically Complex Children, led by the one of our co-directors, Dr. Sefna John. My name is Anna Kate Bogards, and I'll be your webinar moderator for today. Before we get started, I wanted to let you know a little bit about the ARBEST program and do some housekeeping announcements. Arkansas Building Effective Services for Trauma, or ARBEST, is a state-funded program at the UAMS Psychiatric Research Institute, and our aim is to improve mental health services for children and families who have experienced trauma. We work closely with multiple partners to build a more trauma-informed state, and we're probably best known for providing training to mental health professionals on treatments that are effective with helping children and families recover from trauma. Before we get started, I just wanted to go over a few housekeeping announcements about our webinars. For those of you who come often, you've heard this before. So you will have an opportunity to ask questions. There is a question box or feature in the webinar on the right panel of your screen, and you can type a question in there anytime, and we will be monitoring those questions. And then at the end of or throughout the presentation, and then also at the end, we'll have some time to respond to your questions. If you need a CEU or need a record of you having attended this webinar, just make sure that you stick around to the very end of the webinar, and we'll provide you a code that you will use to put into a survey that you'll receive by email. So I'll be giving you more instructions at the end about that. We are recording this webinar, and we will upload it to our ARBEST YouTube channel, so you can check that out. We also have many previously recorded webinars there. And finally, don't forget to check us out on the ARBEST Facebook page. That is where we frequently post upcoming webinars, training opportunities, and other resources that you might find helpful. And with that, I'm going to turn it over to Dr. John and let her introduce herself.
Thank you, Anna Kate. And so, hi, everybody. This webinar format's always a little interesting because I can't see any of you. And so before we even get started, I want to encourage you to use the chat actively. And so if there are pieces of information that are standing out to you for whatever reason, or if this reminds you of something important that you know, I'd love it if our audience can also share wisdom with one another, in addition to me talking with you a little bit about this. And similarly, there is a question box on the right. Please feel free to use that question box. I'll stop at a few kind of times during the presentation, and then hopefully as well leave some time at the ending. So welcome everybody. We are going to be focusing this webinar topic on meeting the mental health needs of medically complex children. And Anna Kate, there we go, it's moving. Okay, so what I'm hoping that you leave this presentation with is a few things. The first is to understand that there is a significant relationship between medical illness and mental health, and that's particularly true for kids with complex medical needs in and out of the foster care system. I want you to understand that there are also caregiver-child impacts that emerge in this population. So it's not just about what are the child's mental health needs or what are the parents' mental health needs, but also considering what are the needs of the relationship when there's medical trauma. And finally, help you understand what are strategies I can do within my own role in order to better meet the mental health needs of this population. So what you'll hear me talk about occasionally is foster care in particular, since we know a lot of our kids with medical complexity interact with the foster care system, but hopefully this information feels applicable to you kind of regardless of the way that you interact with these families. So let's start with just like a shared definition of what are we talking about when we talk about medical trauma. And so for me, important things for you to know is that medical trauma can occur due to a single medical episode, like a very significant surgery, for example, or a chronic medical condition, something like cancer. And how a child and family experience the event is much more likely to kind of be linked to their post-traumatic stress symptoms than the severity of the medical condition itself. And so a lot of times when I first thought about medical trauma, it was really serious instances of medical illness. Things like life-threatening illnesses or chronic medical conditions that really impact the quality of life. And with that narrow view on medical trauma, I think I was missing a lot of the population who has needs. That what is it like for a kid with type 1 diabetes who has to chronically go through medical procedures that might make he, she, they feel different about themselves, about their peers, and may interact the way that they're able to engage in activities that they should be enjoying at that age. And so I want you guys to avoid the pitfall that I fell in initially and really broaden your understanding of what could constitute medical trauma. So what we know is that many ill or injured children and their families, really up to 80%, will experience some traumatic stress as part of a reaction to their illness, to the injury they suffered, or to a painful medical procedure that was needed for their health care. And so instead of thinking about post-traumatic stress symptoms as the exception, we may want to start really thinking about the idea that everybody's going to go through some acute kind of temporary symptoms of post-traumatic stress. Much like we would expect everyone or most people to go through some symptoms right after a car accident, where maybe you're hypervigilant on the road, you're braking much more frequently, you're a little scared when you merge onto the highway, but usually those will fade with time for most people. What we know for medical trauma is between 20 to 30% of parents and between 15 to 25% of children and siblings will experience persistent traumatic stress reactions that impact their daily life and, interestingly, also affect their treatment adherence and recovery to their illness. So it's not only just important to think of mental health because mental health is in and of itself important. It's also important to realize that mental health will impact physical health and the way children and families are able to recover from the physical illnesses that they are experiencing. I'm curious for those of you, if you want to use the chat to tell me how do these prevalence rates, this 20 to 30%, about 1 in 5, 1 in 3 parents, and that 15 to 25%, 1 in 6, 1 in 4 children are going to exhibit significant PTSD symptoms that persist after medical illness, injury, or trauma. I'm curious, just go ahead and use the chat to say, like, is this lower than you expected, higher than you expected, about what you expected for this population? Anna Kate, I'm having a little trouble navigating the slides. They won't move forward when I'm pushing my button. Is there anything that you could do to help with that? Okay, forgive me 1 second, guys. We're running into some tech issues. Anna Kate, if you're there, can you help me figure out how to proceed with the slide? Right now, it's stuck where it is and it's not responding to my controls to move it forward. I apologize to everyone. This may be a weather impact that we're having, at least here in West Little Rock. It is pouring rain outside, so I don't know if that's part of what's going on here. Anna Kate, are you there to help me out? So she just let me know that her power went out, of course, so she's on standby. And so let's give it just a minute. Again, I'm going to encourage you to use your chat to kind of respond to these specific questions that I'm asking you.
Excuse me, everyone. Safna, can you hear me?
Yes, I can hear you. Can you hear me?
Okay. Yes, I don't know what happened. The lights flicked and then my laptop shut down. Were you able to keep moving through
No,
the slides or okay?
no, I don't have control of the slides. And honestly, I'm not sure whether attendees can hear me. So could someone that's an attendee type something in the chat? I've asked people to use the chat a couple times and there's been no responses coming in. So I'm just not sure if people are feeling quiet or whether they actually can't hear me.
I think the chat function on here actually is deactivated, so it would have to be through the question box and they
Got
wouldn't
it.
be able to see each other. So
Got
let's
it.
see if I
Okay.
get some questions come through. Okay, they say they can hear us now.
Ooh, good. Okay, perfect. Sorry
So let
about
me,
that, everyone.
yeah,
And Anna Kate, I still need control given back to me so I can proceed.
okay. Yes, sorry about that, guys. We will get back up and running here. Sefna, sorry everybody. What I'm going to do is email you this version of the PowerPoint and you can share your screen
Okay,
instead of doing it from mine because I'm having some technical difficulties here.
sounds
So
good.
give us just a few minutes, everyone.
Okay, can everybody see that slide?
Yes.
Okay, perfect. Okay, I think we're good. Thank you, everybody, for your patience as we are figuring out the tech side of things. But kind of where we left off was talking about the idea that about 1 in 5 to 1 in 3 parents and 1 in 6 to 1 in 4 kids are going to be experiencing persistent PTSD symptoms that are impairing to them and infecting their treatment adherence to their medical condition. And so this is something we should all be paying attention to, but particularly those of us who work within systems like medical care, primary care, foster care, in which we're seeing a lot of kids with these types of difficulties. And so what I want you to get a sense of first is, how does medical trauma actually manifest in child mental health? And so what you can see on this wheel here is there's a lot of different ways that medical trauma can affect kids. I'm going to highlight just a few that I think are particularly relevant and most likely to manifest in the types of roles that you might have. The first is body reactions. That what we know is that kids who have experienced medical trauma may also be showing the toll of their mental health in physical ways as well. So you might see kids complain of more things like general headaches, stomach aches, or fatigue. You might see children who used to have pretty intact developmental milestones start to regress. So for a younger kid, a kid who was pretty potty trained might start to regress and not be potty trained anymore. They could really become extra sensitive to being touched by others, that it may not just be, I don't want my body touched because my body hurts. It might also be, I don't want my body touched because people have touched my body in a way that causes pain as part of my medical trauma or the medical interventions that happened because of physical health issues. And this is in combination with the physical impact kids are already having because of their medical illness. And so what this means is, in many ways, I feel these physical symptoms due to post-traumatic stress disorder are often missed because people are just considering them to be part of the physical health condition, and they might miss the idea that actually this really might be indicative that we're running into a body reaction to trauma as well. What we see here as well is that kids may have trouble controlling their feelings. So I want you to think about, if you've been through any medical difficulties or just chronic illness in general, how that impacts your mood. And remember, as adults, we tend to have more sophisticated brains, more wise bodies, and more years on the planet to be able to figure out coping strategies for how we want to manage feelings. Kids are already at a loss in this area. A typical kid has trouble controlling feelings to a large extent. And then when you think about the idea that kids have been through trauma, those difficulties can be even more pronounced. Again, what I want you to do is pay attention here to both sides of this issue. We often see kids in our offices, if we're mental health clinicians, with under control. What that means is they can't control their feelings very well, so that might show up as excessive crying, worrying, anger. And we also want to pay attention to kids who are over controlled. What that means is they may look numb or blunted. They may not show happiness or joy to the same extent that we would expect others. And both of those are concerning. We're concerned about the under control, and we're concerned about the over control, because many kids who are over controlled fly under the radar because they're not really causing any problems, because they have blunted affect or difficulty expressing themselves. And so we want to be be on the lookout for both of those types of presentations for feelings. And that's similar for behavior too. One of my favorite phrases to explain this to others is, for children, behave stands for I have something to say. That in many ways, children show us how they feel based in their behavior. And we want to pay attention to under control and over control here. Kids who are under control might have more aggression, temper tantrums, self-harm or self-injurious behavior. But on the flip side, we also want to pay attention to kids who are what we call mechanically over-compliant, meaning they're not really having even normative levels of behavioral difficulties. We expect kids to push back a little bit. I mean, that's part of developing independence and autonomy. But what we often see in kids like this is they've resigned themselves to really having low behavioral output, period. And so again, remembering to think about over control and under control here. But medical trauma doesn't just impact a child. I am a parent myself. I have a 6-year-old and a 3-year-old. And I will tell you, at least for myself, I would much rather myself go through pain than my child does. And I think a lot of parents have a similar value to that pain in our children is harder for us to cope with than even pain in ourselves. And so we want to pay special attention to how caregivers are coping and managing with the trauma in their children. Again, this wheel should look familiar to you because this is actually how medical trauma impacts kids as well. This can go across the board for parents. And again, I'm going to highlight a couple few areas where I think could be especially important for caregivers. The first is thoughts about the world. And so what we know is when you go through medical illness in yourself or in someone else, for people who have strong ties to spirituality or religiosity, this can impact that worldview. And what's important to know and be humble about is we don't know how it would impact their worldview without asking or listening carefully. Because for some, faith is an important part of how they cope with the heartache of medical trauma. Phrases like, God would not give our family more than we can handle. Family members who would want to know about chapel services or other religious services that could support them. Families who, because of medical care, need things like meals delivered to their home, which is often a time where faith-based communities really step up to take care of those around them. On the flip side, there may be some that their faith is largely undermined by medical trauma. How could a God that I believe in allow these things to happen to my child? It is difficult to bear witness to suffering and believe that everything is what it's meant to be. Those things are hard to reconcile for a lot of folks. And so what I want you to pay attention to is not just a blanket statement of medical trauma impacts faith communities. Instead, I want you to be curious about that and to ask people around you, how has this impacted the way you look at the world, the way you worship, the way you interact with peers? What are the significant impacts of going through an illness process like this? Also for adults, we use coping strategies that are built into our bodies called dissociation. And so a normative amount of dissociation is actually fairly common no matter what your psychiatric health history is. And so I'll give you an example. If you've ever been driving your car and you're going to a familiar place and you park your car in the parking lot and you're like, I don't remember driving here at all. Like, I'm sure I was hopefully paying attention to traffic laws. I don't remember taking any of these turns. My body kind of checked out. My brain kind of checked out at that moment, and now I'm back. Okay, that's a more typical type of dissociation. What we often see in trauma is that people's bodies dissociate during periods of high stress because staying in the moment would be exceptionally painful. Can you imagine what it would be like to be connected to your body during a long, painful medical procedure? We wouldn't want that to happen. We actually give people anesthesia so they aren't connected to their bodies in that moment. However, for most people, when they leave a medical facility, they don't have the same access to ways to numb pain than they would have had in the hospital. And so what we know is staying in the moment and interacting with your child can be difficult when you are dissociated. And that dissociation, even though it's protective during trauma, it can actually get in the way of you forming and meeting the needs of others once you're out of that specific trauma moment. And so I'm going to ask you a rhetorical question here, not necessarily something that you need to answer out loud, but I want you to think about, what might be some reasons why caregivers would dissociate during a child's medical treatment? Why would a caregiver kind of check out in these moments? Okay. I think for some people, they would argue, don't check out now. This is when your kids need you the most. And I agree with that. And parents are people too. And it can be really hard to stay present in moments that are very, very scary. Okay. So before we get into the impact of medical trauma on the caregiver-child relationship, we've briefly gone through what is medical trauma, how does it impact child mental health, and how does it impact parent mental health. I want to stop here for a moment and encourage you, if you have any questions, go ahead and use the chat feature to type in a question. Excuse me, not the chat feature, there's a question specifically. I'll wait just a minute to see if anybody has any questions that have popped up yet from content that we've gone through. If not, we'll keep going and save questions for the end.
There are any questions, right? Oh, here, one just came in. Let me ask this for you.
Sure.
If you feel you are working with a parent that is experiencing dissociation, what tips would you recommend from a provider social work standpoint to help that caregiver?
Yes, this is such a great question. This is a hard one because one, how do I recognize someone's dissociating in the first place, right? And so for some people that looks like more difficulty tracking the conversation. For others, you might notice they're not giving you reciprocal facial expressions or eye contact, things that might suggest they're not connected to the here and now. What I typically do is start with a normalizing statement to that we're talking about really hard things, and sometimes our bodies pull us out of those conversations. And so what I'm going to try to do is see whether we can pull your body back into this conversation so you can know all the information you need to take care of your child. And so I will typically use one of two things. One is language-based, one is not as language-based. And so this gives you a few options. A language-based option is to use a 5-4-3-2-1 method. And so this engages sensory input. So you could say, why don't you go ahead and tell me 5 things you can see in this room right now, 4 things you could hear, 3 things you can smell, 2 things you can touch. So you go through sensory experiences because that can often ground people in the room and in the moment, okay? When I know that someone has a history of dissociation, or frankly, I think it could be a potential, I might have them practice that before we even start talking about difficult things, so it's not something that completely throws them off once you do it, okay? So that's a verbal way of doing it. The nice thing about a verbal way to ground someone is it doesn't involve physical touch, which means that you don't have to worry as much about what someone's comfort level would be with you physically touching them, okay? The flip side, another alternative is a grounding technique in which you use touch. Okay, what this might look like is me taking my foot and tapping it against the foot of somebody else, or me taking my hand and gently placing it on the hand of someone else in order to ground them and bring them back to a space. Okay. The benefits of a method like this is it's not very verbal. So for people who have different verbal capacities or people who are really checked out and are not able to even pay attention to verbal input, this might work well. The thing to remember about this is people respond differently to physical touch in general, but especially people who have been through trauma might be very sensitive to physical touch. And so I want you to have more than one tool in your toolkit to manage dissociation, depending on who's sitting in front of you. Okay, but I think that it's a great idea to pay attention to if someone's tracking you and with you, and if they're not, to take the moment to pause and try to ground them before you continue on with the conversation. I hope that's helpful. Anna Kate, any other questions came up?
No, that's it.
Okay, perfect. Well, let's keep going. That was a great question as we think about how does medical trauma impact the caregiver-child relationship? So for this, you need to know about some principles of child development, okay? The first principle is that memory starts at birth. You're never too young not to remember something, okay? There's a difference here between I remember it in my body and I remember it where I can verbally talk about it. Okay, I remember when I first heard this idea, I was like, what do you mean babies who are really infants can remember things? That just felt wrong to me. And I don't think it's a way that society talks about memory a lot. But let me give you some research to hopefully help seal this in your mind. The first is that, we tell expecting parents to sing the same lullaby to their child or to talk to their child a lot, or to read their child the same story. Because what we know is within hours, actually, of babies being born, they will orient differently. They will pay attention more to songs they've heard in the womb, voices they've heard in the womb. We've heard those stories of after you give birth to a kid, you speak and your baby immediately pulls attention to you because they recognize that voice. And I would tell you, how could they recognize it if they don't remember? Similarly, why does your baby treat you differently than a random adult in the room? Again, because your baby can remember you. And so even though memory capacity starts at birth, this is going to be differently expressed for people who are verbal or nonverbal. There's a famous trauma saying that says your body keeps the score. And for many pre-verbal children, you will see these impacts in the way that they manage their body versus necessarily the way they talk about things, okay? The next core principle of child development I want you to realize is that children develop within the context of relationships. For young children, this means that kids rely on adults for everything. They rely on adults to make sense of the world and rely on adults to help them cope with their own emotions. As children get older, they need caregivers to hopefully model positive coping, to encourage positive coping strategies in their kids. So when you're thinking of taking care of a child, I want your brain to automatically say a child and who. Because when we're in childhood, the grown-ups are really important to pull into child treatment, okay? Because the greatest predictor of how you do after you experience trauma is the presence of at least one attuned caregiver that can buffer the negative impacts of stress. It's not how old you are or how serious your trauma is. It's not your gender. It's not your age. It is, do you have at least one adult who can consistently show up and be present for you? And so as people who have high compassion for children who go through trauma, we really need to be developmentalists here. We need to recognize that in order to help children, we need to equip the grownups that are around them all day in helping them to manage these impacts. Those grown-ups could be parents, those grown-ups could be teachers or childcare providers, those grown-ups could be caseworkers if kids are in foster care. And so we really want to equip adults across the board to understand and respond to the needs of kids who have experienced trauma, because we know that's what's going to make the biggest difference. Medical trauma can really impact safety within a caregiver and child relationship. So attachment to me is one of those words in mental health that's kind of like synergy in business, where everybody uses it, but it's kind of taken on so many different meanings, some of which really aren't attachment. So what I want to do is first focus us in on what do we mean by attachment. So attachment from a developmental lens really refers to how do children seek comfort and accept comfort in frightening or novel new situations, okay? And so what we know is attachment isn't a fixed thing. You're not like, I'm attached or I'm not attached. Really, attachment and the quality of attachment unfolds over thousands of interactions. So if I was going to ask you, so think of someone in your life where you feel really safe and secure with them. What was the single moment where you were like, oh, this person's it? They're the person I trust and feel safe with. Most people can't identify a single moment because instead it's thousands of moments, hundreds of times that someone showed up for you in little and big ways for you to realize they were someone you could count on. And so what we want to pay attention to in attachment is how is the experience of medical trauma impacting children seeking comfort and accepting comfort in these frightening situations, because that could really have an impact in how they establish attachment and a relationship. And I can see three big ways this could manifest, okay? The first is, especially young children often believe that their caregivers are all knowing and all have all power, right? You are a superhero to young children. You're capable of anything. And so if you have that worldview, what would it be like to go through something scary and dangerous and your caregiver isn't doing it? They're not fixing it. If I thought someone had the power to fix something and they still let me suffer, that could really undermine my trust in them. And so one of the things we have to realize is developmentally, young children have concepts of caregivers that aren't realistic. And as caregivers, we need to explicitly say that. So say things like, oh, buddy, I wish I could take this away, but I don't have control over your body. I will be here though when you're going through scary stuff to hold your hand or to give you kisses or to make sure I'm trying to have you feel as little pain as possible, right? And so what parents want to do is avoid promising things you can't promise. Like, you're definitely going to be okay. We can't promise that. However, what we could do is suggest things we could reassure people of. So this folds into that third bullet here of caregivers often aren't trained or equipped to explain complicated things to children. So they resort to these placations and these generalizations that unfortunately aren't true. And so if a parent says, don't worry, this won't hurt, how many of us have seen that in doctor's offices where kids are about to get a shot and parents are like, this isn't gonna hurt? Yeah, it is. Like, it's not going to feel good to get a shot. And so what does it feel like if your caregiver just told you this isn't going to hurt and then it did? Either you could think my parent's lying to me or my parent has no idea what they're talking about. Either of those conceptualizations aren't great for the trust in a parent-child relationship. And so instead of this won't hurt, it might say, this is going to hurt a little and I'm here to hold your hand. Or this is going to hurt a little, but it probably won't hurt a lot. Right? And so that way we can start being more accurate with children as we're explaining medical care. And then finally, caregivers are often responsible for a great deal of medical care. Okay. One of my medical trauma cases that holds the most special place in my heart was working with an 8-year-old child and his caregivers after he was in a significant fire and had a lot of burns. And I don't know if you're familiar with burn and wound care, but it is exceptionally painful. And when asking this child about what was hardest, it actually wasn't the fire for him. It was all those moments was his parents are, quote, mean and hurt him by changing his bandages or doing wound care or hurting him in the shower when they need to clean out his wounds. That for him, that was the scary part. is that you're my parents and you're supposed to love me. Why are you hurting me? And for the parents to say, it's awful. It's awful for me to have to sit here and hurt my child. I know it's best for them and it kills me to do it, right? That's really hard for me to fulfill this role. And so caregivers in those moments, hearkening back to earlier in this presentation, they might dissociate. They might grit and bear it because that's the only way they can get through it. But that means in those moments, they're not attuning to their child. And so as a provider, this might mean you want to ask explicitly about those moments. Tell me a moment that was really hard in taking care of the physical needs of your child. Or child, what's scary that happens at home when your body hurts? And what does mom or dad do, or grandpa or cousin do when they're taking care of your body? Because those moments might be really important to think about. Okay. So what I'm going to do here is do another quick pause to ask if anybody has any questions in particular about how does medical trauma impact the caregiver-child relationship. I'll give you a second to put those questions in, and then Anna Kate, you can let me know if anything comes in or whether we're good to move on.
Okay.
Okay, why don't we keep going? And if people have questions, please feel free to send them over to Anna Kate. We'll have a block of time at the end to answer some more of your questions and then hopefully get you out of here with at least a few minutes to transition to your next activity in the world of Zoom that we all live in. So hopefully what this presentation has done in the first half is help you understand what is the relationship between mental health and medical illness, and how am I going to be more thoughtful and pay attention to the impact of mental health within the conversation of medical care, okay? And now what I want to do is empower you with specific strategies of what you could do. Some of these might seem more applicable or less applicable to you depending on what your role is. What I want you to I'm giving you permission though to imagine. Sometimes our natural human brain tendency is to shut down new ideas because it's not what we do now, so it doesn't seem feasible. And if we want to change a system, we have to do things that are new. And so I want to empower you to consider these ideas with an open frame of what would I need to support me doing this, as opposed to that wouldn't work. I could never do something like that. And so if there was a tagline to my career, y'all, this would probably be it. In that fostering resilience in children means investing in the adults who support them. We are really in the business here of widening our compassion lens to include adults. Because one thing we haven't talked about is for a lot of medical illness, there are heritable and biological tendencies at play, which means that for some of these caregivers, they also struggle with this health difficulty or did as a child. And so watching their child struggle can be extremely trauma triggering for their own current trauma or what it felt like for them as a child to go through something like this. And if we want to make a difference for children, we need to invest in the adults who literally take pieces of themselves and build their children, right? We need to focus on this as well as this. So what I encourage you to do is know your team and know how your team would do group learning on a topic, okay? And if possible, encourage that caregiver to do learning alongside you. So for me, as someone who works in a hospital at Arkansas Children's Hospital campus, there are plenty of times where kids come into care and I don't know what their genetic condition means. I don't know what their specific health concern means. I think when we're trained to be like the expert, quote unquote, in front of parents, we feel shy or embarrassed to say, I don't know information. And maybe that models for parents that they should also feel shy or embarrassed if they don't know information. So instead, I encourage you to ask a caregiver, you know, you came in and said your child has this strain of this illness, and I don't know a lot about it. Would it be helpful for us to spend some time together looking it up and digesting this information? So build it into the idea that this is part of the work we do is we learn together. that also gives the caregiver an opportunity to be a teacher. Okay, there's a lot of power differentials in therapy where the therapist is this expert, the parent or child are just a recipient of care, and it doesn't lend itself well to collaboration. So group learning can actually be a way to even out that power differential and help you and the family get on more even footing, where you could learn together, or parents could teach you, hey, no, that's not actually how it looks to me. And so please don't confuse this with me saying it's up to your families to teach you everything. You have a responsibility to learn. I'm just saying that that learning might be able to happen jointly with a family member at times. Okay? We want to reinforce the idea that it is a collective team responsibility to understand child well-being. Medical providers cannot say the mental health side is something they don't think about because they're interrelated. Similarly, mental health providers cannot go, well, that medical stuff is up to the doctor. I don't know a lot about it. Instead, what we want to build is a community that understands some of both, because families are having to navigate all the systems at the same time, right? So if we silo, that's not actually helpful to the family because they have to see all of it at the same time. And one strategy I have found particularly helpful is find your phone a friend doctor. Find a doctor in your community that you know will be responsive to an email or a phone call. If you are a physician or a nurse or a medical provider, find a mental health partner who's willing to answer your emails and do some learning with you. Build personal relationships with providers because that'll help you feel more comfortable with contacting them to learn more. Okay. Another thing I want you to do is center mental health needs within medical discussions. Okay, so as we talk to people about medical care, we should be routinely and regularly also checking in on mental health care, right? That these things are not separate. It's not like, oh, hey, let me go grab the psychologist or the social work nurse. She's going to be the one that talks to you about how you're feeling. Could we find a model in which both those providers know at least a little bit about what each other does, and so it doesn't feel as broken down for families? Okay, we need to check in regularly and check in on pragmatic needs because they often have a significant mental health association. So if someone doesn't have transportation to medical appointments, that definitely impacts their mental health and the stress they are experiencing in caretaking. And so it shouldn't only be our care coordinators or our social work support that knows how to find resources for a family. It could also be that others of us need to learn how to find resources and do that again alongside a caregiver so they can learn the skills as well and how they would have to navigate things. I was never more humbled. My youngest son requires speech therapy and physical therapy. And I thought, oh, I'm totally going to nail this because I'm an early childhood psychologist. I work with kids all the time. I work at a healthcare organization. I'm totally going to understand what to do. No, I found it incredibly difficult actually to navigate the developmental services space to be able to get my child the services he needs. And what that made me even realize is a humble check of like, I had the best of resources as someone who has a high degree of education, high degree of income, is flexible, is familiar with this topic area, and I couldn't figure out very well how to access services. So a lot of families who are more under-resourced for a variety of reasons really might need your actual assistance in doing some of these things. And that could be a part of the way you spend your mental health care appointment, is helping them to find resources. Instead of going, here's a sheet with the contact information for a mental health intake, you might go, let's call that mental health agency together and book you for an intake right now. So that way, instead of pushing responsibilities to a caregiver who's already overly taxed, we do that together and take something off their plate instead of putting another thing on their plate. We want families to get assessed early. Remember, I told you upwards of 80% of children will experience some symptoms of post-traumatic stress after medical illness, and up to 1 in 4, those symptoms will be persistent over time. We cannot wait for children to develop severe problems before we get them assessed by a mental health clinician. We have some areas in which this works well, where we might have mental health staff integrated into a primary care setting, things like the Healthy Steps program for young children. But often kids don't get assessed by mental health until it's really late in the game. And so you might want to start early, work with your PCP providers in their agency, work with foster and caseworkers to help them understand the idea that getting mental health needs assessed and treated if they're present can stabilize placements in foster care. It can reduce the burden and transition for kids who are already struggling. And so we need to think more preventatively about this idea. Mental health care isn't just for when you're seriously struggling. Hopefully, ideally, what it can do is also prevent you from getting to the point where you're significantly impaired. Okay, so in these moments, adjustment disorders may be our friend, that really we are working with kids in that adjustment period to try to help them cope with those types of difficulties. Remember and explain to families, not all services are created equal. This is probably a message you hear from the Our Best team a lot, is that vulnerable families deserve the best we have to offer. And so if you're choosing between types of therapy for them to engage in, many times it's wisest to pick the therapy that has the most evidence that it works. So evidence-based treatment services have been tested with hundreds and thousands of families in some of them to make sure that they work. And so as we're providing referrals for families, we need to think about what would be evidence-based for trauma services. Particularly for young kids, evidence-based services should be predominantly dyadic, meaning parents and kids are together in sessions. And I would argue that appropriate caregiver involvement in services is a good active ingredient no matter how old a child is. Because remember, I told you, medical trauma impacts the whole family. It's kind of like domestic violence in that way, where it's an event that impacts everyone to a different degree. And so you might want to have all those people involved in your care because they're equally going through an event, but they might be experiencing it very different. Let me see if I can get this moving. Okay, so just like not all treatment services are created equal, we need to recognize the idea that not all populations experience trauma to the same degree. How people look, where people are from, what their ability status or social economic status is, their gender identity or who they love, their immigration status or language that they speak, all of these things can impact their exposure and response to trauma. And unfortunately, what we know is marginalized groups often have much more difficulty in accessing evidence-based services. What I want you to see is that's true for mental health and medical care. So what we see here is compared to white children with cancers that should be responsive to treatment, kids with the same tumor type were 63% more likely to die if they were Hispanic and 59% more likely to die if they identified as Black. And that similarly, children of color consistently have lower access to mental health care after injury. And so we want to pay special attention to those around us who are even more vulnerable and be open to talking about those issues of diversity, equity, and inclusion with our families and with our colleagues. So if you don't know where to start, it can be hard to know, like, how do I talk about this? At the back of the DSM, but also if you Google it, there's something called the cultural formulation interview. It gives you sample questions of how do I ask about elements of culture that might be impacting what I'm seeing and how I can partner most effectively with the people in the room. It might give you a place to start and how to bring these things into the room. I want you to be brave and courageous in talking about these things because they're impacting families whether we talk about it or not. And I want to be cognizant that most of the time when we don't talk about it, it's not because we don't care, it's just because we don't know how, and we're worried about hurting somebody. And so things like the cultural formulation interview can give you a template to try out and then later modify so you can start these conversations going with your families. Okay, I want you to be very, very thoughtful about language. Consider presenting information in multiple ways. So speaking it, writing it down, having people put phone alerts in their phone, because what we know is that understanding medical illness can be hard for people who've gone through trauma in multiple ways. First, trauma distorts your memory. And so as trauma is processed, someone's understanding and comprehension of events can change. Similarly, trauma can disrupt cognitive and language development. And healthcare language is already hard. Y'all, we are already a jargony bunch. And that's especially hard for people who might have disruptions in their cognitive and language development, which is common to see in people who have gone through trauma. So a quick tip, if you don't understand a term, you should be the one to ask a clarifying question. So if I'm with a family and a caseworker and the caseworker says something complicated, I might be the one to say, so by respite care, are you talking about like that families, their kids are taken care of by other vetted adults to give the family a break? Is that what you mean by respite care? Because that way I'm the person who asks the question. A lot of times, especially in foster care, parents are trying to show us they are ready and able to take care of their children, which makes them reticent to ask us questions if they don't understand something, because they don't want us to read into that as they're not capable. And so you be the one to ask, because honestly, if you're struggling understanding something, it is probably the case that many others in the room are having trouble understanding that concept as well. Similarly, make it a standard part of your practice to start decoding when you use acronyms or when you speak jargon. Have it be something that you start to catch in yourself of going, oops, I said this. This is what I meant by that, right? So we're also modeling that that's a normal part of the way we engage as a team, is we ask for clarification. And that's a respectful thing to do within a meeting as opposed to a disrespectful, argumentative thing to do. Okay. Get curious. So today we've been talking about the potential impacts of medical trauma on mental health, but trauma is not deterministic. Okay, not everyone responds to trauma the same way. And often we as clinicians and humans assume that if someone's engaging in poor behavior, like let's say they're not taking their medicine or they're not practicing a breathing strategy we taught them, we assume that that reflects poor values. They just don't care. This doesn't matter to them as much. But what we know is most of human behavior isn't solely dictated by values. So a great example of this is I am totally on board with screen requirements and restrictions for kids as they're developing, right? I think it's a great idea. And during the pandemic, my kids have watched a lot of screens, a lot of iPads, a lot of TV, because y'all, it's the best I can do as a working professional. That doesn't mean I don't have value for screen time and brain development. It just means I don't have the capacity right now to hold that value up the way I want to. And so what we need to do is be curious. It is very difficult to intervene effectively on that which you don't understand. So even approaching something with a curious, a genuinely curious stance can also help you know, how am I more effective with somebody if I'm approaching it through curiosity? And the last thing is a reminder that building emotionally safe relationships takes time. Remember, I told you caregivers and children build attachment over thousands of interactions. That's true for families we serve too. We know we're safe and invested, so it's difficult for us to remember and understand why people don't implicitly trust us. But we're associated with systems like healthcare or child welfare or mental health that are mistrusted by certain members of our community for valid reasons. And so I want you to be asking yourself intentionally, what am I doing to create trust? Knowing that being transparent and genuine and forthcoming and humble are usually strategies that build trust in others. Okay. The example I use for this is an M&M example, if this helps any, is if I had a bowl of M&Ms in front of me and slid it over to you on the desk if we were together in person right now, and I said, go ahead and take a handful of these M&Ms. Oh, by the way, only like 2 or 3 out of the whole bowl are poisonous. You can't really tell on the outside, of course, but it's only 2 or 3 of them. Go ahead and take a handful of M&Ms. Most people would never take the M&Ms, right? It's not worth the risk of the 2 or 3, even if almost all of them are good. This is true for us. We look a lot like M&Ms that might have hurt, doctors that might not have listened, therapists that might not have heard, right? Professionals that may not have given you what you needed. We look like those M&Ms. We feel like those M&Ms. Why would we expect people to trust us? Unless we can intentionally show them, I am a safe M&M. Here is what I'm doing to show you that the type of M&M I am is safe. And I want to leave you with that as you think about your clinical care with vulnerable populations. What are you doing to be a safe feminine? So what I'll do is have my email address up here. You are not bothering me at all, actually, to email me after presentations. I would love your feedback on what worked for you, what didn't. If you have any questions, I'm happy to think through answers with you. I love hearing from folks after webinars, so feel free to email me. There's also some information here about Best, how you can access clinician lists to see who in your communities are trained in evidence-based trauma treatments. You can find information about how to join an evidence-based trauma treatment. And then we've got a Facebook group as well that posts a lot of nice trauma-informed content. And so, Anna Kate, I think we need to flash a webinar code. Is that right?
Yes, just go to the next slide.
Perfect. And so this is the code that you'll need to get credit for you being here. Anna Kate, were there any questions that came up in the chat?
There were a few people that commented that they thought this was really helpful, so that's great.
Oh, I'm glad.
I had a question that might be helpful for some of our attendees. What would be some considerations for engaging a child into trauma treatment when they had a chronic illness or some kind of ongoing medical issues that might prevent them from being consistent in treatment? What might you consider when you were trying to decide if they were good for treatment or not?
Yeah, it's a great point. And there's a couple questions here. One is, can you actually consistently engage in treatment? And am I able to be flexible around that? So if you have a kid, for example, where it's painful for them to sit in your appointment for an hour, can you reduce the length of your appointments or change the configuration of your physical space to make sure they're more comfortable? Similarly, if kids have medical needs they need to address during sessions, like they are prone to seizures or they have medication, that you talk with caregivers openly about what you would do and how they want to manage that. Okay, so there's pragmatics you want to think about. But for me, in some ways, going through medical trauma is a lot like trauma in general, where you're going to expect kids to be avoidant. Many kids and caregivers don't want to talk. Well, who of us wants to talk about the scariest and hardest things we're dealing with? That's hard. And so a lot of our treatments, especially evidence-based trauma treatments, have a lot of specific suggestions on how to combat avoidance. So for example, in TFCBT, we want you to talk about the trauma in almost every session. So that way it's almost like going into a pool in the shallow end gradually, as opposed to dunking someone into trauma processing really, really quickly. Okay, and so part of it is, if you want to know how to address these well, and you're a mental health professional in particular, please consider signing up for one of our evidence-based trauma treatments, because you're going to get a lot of targeted support on how to manage mental health needs. But for everybody else who maybe isn't going to do a full course of treatment with people, I would suggest you really pay attention to pragmatic and physical health needs, because that's going to really, if people aren't physically comfortable, it's going to be much harder for them to engage in mental health treatment.
Mm-hmm. Great, thank you. I'm going to answer a question real quick about the webinar code, and then we have one more question I think we have time for.
Sure.
So the webinar code you will put into a survey that you will receive by email from me here shortly after the webinar. So hang tight for that email. If you don't receive that by the end of today, then you can contact me and I will make sure that you get that. The question that came in was they were wanting to know what are your recommendations for parents of children who have chronic abdominal pain when it's unclear whether it's medical or related to a mental health issue? How do you balance validating the pain and using coping skills?
Yes, you do that individually with the provider is the biggest answer. Is each kid is different. But I usually tell folks that come to my office with GI issues in particular is that you need to get a full workup medically just to make sure. It's similar to like if a kid is having a lot of like toilet accidents, we first want to rule out medical conditions. So like there might be a serious reflux issue or something that's causing the physical pain. And in the meantime, even if something's physical, there are often strategies that we can use to help people cope with pain that are in the mental health arena. And so for parents who are worried, like, oh, I don't want to keep validating this, or I'm worried about reinforcing it, oftentimes a quick validation statement like, oh, you're telling me you're in pain. Let's do some deep breathing together. So you're able to manage that pain better. Or, oh, you're telling me you're so tired. Why don't we turn off the screens and go take a nap for a little while to help your body calm down and get some more energy? And so usually, typically, I would encourage adults to do a quick validator and immediately move into a coping strategy. But first and foremost, get things medically checked out and work with your therapist so they can individually tailor your parent response to all the other factors that are going on for your child and you as you're navigating this mental health issue.
Wonderful. Thank you, Dr. John. That was a really helpful presentation, and we will make sure to put this recording up on our YouTube page. Our Best will have another webinar again next month, so we hope to see you there. And thank you, everyone, and I hope everyone has a great day.
Thank you, everyone.